Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Supreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Hello, and welcome to this episode of the MenopauseWize podcast on Better Sex at Menopause with Dr. Laurie Brotto. Dr. Brotto is a globally recognized leader in women's sexual health, a professor, clinician, and lead of the Women's Health Research Institute in Canada. Her groundbreaking work on mindfulness-based treatments for sexual dysfunction has shaped international guidelines and practice. In recognition of her contributions, she holds a Canada Research Chair in Women's Sexual Health, has received recent awards in mentoring junior faculty, excellent public education through media, book awards, and ranks among the world's most cited scientists. So excited to have you here, Dr. Brotto, and talk about a topic that just isn't spoken about enough, especially where I come from. But I think globally we have the same problem. Um, let's just jump in with a little idea about the desire and arousal and the difference between the two.
Yeah.
We don't even think about them as different aspects. So if you could just
No.
explain for our audience the difference between them.
Yeah. Great. A great question to start off with, because I always think that vocabulary and really understanding what we're talking about is foundational. And in fact, when people have sexual concerns, sometimes it's because we're using different language to refer to the same thing. So, desire typically refers to the motivational aspect of sexual response. So, it's the feeling of wanting, of interest. It need not necessarily be a sexual wanting. It could be a wanting to be close, a wanting for connection, a wanting to get to sleep, a wanting to celebrate a birthday. And we can talk more about responsive desire and what that means. But it really does kind of tap into the more intrinsic interest or motivation. Whereas arousal, we tend to focus a bit more on the response of what happens in the body. Although even arousal can also be in your mind. You could have an aroused mind that's attuned to sexual cues and sexual triggers. But more often than not, especially in women or in females, we associate arousal with, an increase in blood flow, maybe changes in skin sensitivity, changes in muscle tension that reflect an increasing level of sexual response that's happening in the body.
Mm. So, would it be correct to say that the arousal would follow desire, or is it the other way around?
Yeah, I'm really glad you asked that question, because for the longest time we assumed that desire came first. And right, first you're interested in sex and then your body gets aroused and excited. And while that may be true for people in the early stage of a relationship where you're fantasizing about the person, you're planning to see them, you're imagining the sexual encounter, what we actually know, and a lot of data has verified this, is that in the context of a long-term relationship, it's often the other way around. So the person might enter a sexual encounter, again, for non-sexual reasons, like some of the reasons I provided earlier, but without desire. But with focus and attention and the right kinds of stimulation that work for that person, arousal starts. And if that continues and it's wanted, then desire can emerge from that. We call that responsive desire. And a lot of women in particular who hear this description of arousal first, desire second, feel very validated and normalized, because for a lot of women, again, in long-term relationships, they may not have desire at the outset. And that's not a signal of having a sexual problem or being broken or not liking your partner or anything like that. It's really more of a feature rather than a bug of the sexual system.
Mm. Well, that makes a few things clear. But So we know that desire is a function of many different things. One of them being, of course, testosterone levels, and then we have vaginal dryness, which again contributes to the whole the whole fear of pain during
Yeah.
sex.
Yeah.
But if we have, let's say, put those aside and said, okay, we don't really have a problem there,
Yeah.
and we are going to look beyond that, is there anything specific to perimenopause and menopause that can affect our desire and arousal?
Yeah, great question. And that's, I think, clinically, because I'm licensed and operate as a sex therapist, registered psychologist. That's often the question that I get asked is, are the hormonal changes that are happening through the perimenopause and beyond contributing to my low desire? And the short answer is no. And we know that because there's actually been a lot of research that has looked at this question. Now, as you pointed out, definitely the drop in estrogen that can create genitourinary syndrome of menopause, vaginal pain, and if there's fear of pain, that's going to have a direct impact on your interest in sex, your motivation for sex, but it's an indirect effect. And what we often find is when the pain is managed and treated, then desire is resumed. So that said, we do see a drop in sexual desire through the perimenopause, and very large study, many studies actually, longitudinal studies that have been done have found very interestingly that in women, although desire is related with age, right? So desire goes down the older that a woman gets, her distress doesn't necessarily continue along that pathway. So you might have low desire, but not be distressed or bothered by it. You might say, well, of course I have low desire. I'm whatever your life circumstance, however,
Mm,
sort of insert the blank. So what we have found in the very large studies is that it sort of peaks in the perimenopause, where low desire coincides with clinically significant distress, right? So the
mm,
peak of that is kind of in that early 50s age range, again, which coincides with menopause, the average age of menopause. And we would consider that a sexual desire disorder, if you will. So clinically significant levels of low desire.
mm. So basically, what you're saying is at perimenopause, we're looking at not only a drop in desire, but it is associated with her being women being bothered by
Yeah,
that low desire.
yeah,
Um,
yeah. And bother is a good synonym for alternative word for distress.
mm. And what about beyond that? It does do those two graphs dissociate?
Yes, they do. So what we find is that women get less distressed over time.
Mm,
Now, we can pose lots of questions for why is that? Are they resigning themselves? Are they, sort of saying, oh, well, beyond menopause, women aren't sexual anyways, right? Which, by the way, is a myth. We no, we don't want to believe that. So is that why the distress is going down? Or have they learned kind of coping strategies to work with the low desire? They learn to plan sexual activity more. Maybe they're using a variety of different and novel techniques to elicit desire and arousal, and that's why the distress gets less. We don't know. I think for every individual person, those are really important questions that are worth asking.
mm,
But all of this, I think the really take home message for me is just how important it is that we're asking about sexual health at midlife, and we're also asking about distress associated with it.
right. And if it doesn't distress me anymore, should that be a symptom? Should that be something a physician um, or anyone should be nudging this woman to? Because let's say my bone density isn't bothering me today,
Good
but
point.
should I be nudged to have better health today to go,
Yeah.
to improve my bone density? So similarly, like sexual health is health, and should this woman be uh, inspired or motivated to do
Yeah.
something about it is the
Yeah,
question.
that's a great analogy with the bone density, and we would look at that and say, well, that's silly. It doesn't matter if she's distressed or not. This is, a medical problem that needs attention. I think this is where, it behooves all of us as healthcare providers to really ask the careful questions, because what if she comes back and says, my partner has a physical disability that makes sexual activity impossible, and he or she has their own changes in sexual desire, and there's all these other things going on.
Right.
And
Right.
so I think it's a tricky question to have, but I think the first part of your question, which is, we absolutely want to inspire and encourage healthcare providers, particularly primary care, because that's where women go. They go to primary care first before they see me or you, right? The
Yeah.
specialist. They go to primary care first. And so those are the really important questions to ask.
And most of us aren't asking. I think that's where they're falling in the cracks. Um, can we actually improve? You mentioned mindfulness, and
Mhm.
I've listened to some of your work on
Yeah.
mindfulness and sex, and I was like, oh my God, is this the same mindfulness you talk about? Like, be mindful about eating.
Yeah.
So, if you could explain mindfulness and sex, and
Yeah.
just the concept of mindfulness, and then
Yeah.
how does one be mindful with sex?
Yeah. Yeah. I mean, mindfulness is really not anything new. It's kind of evolves from meditation, which of course has been around for millennia, a long time. Mindfulness is a secular adaptation of meditation. It doesn't require any particular religious affiliation. There's no mantras. Essentially what it is. It's a practice of present moment, non-judgmental awareness. And so it's been around for, since the late 1970s. Certain individuals like John Kabat-Zinn and others have really been credited for bringing meditation into the kind of mainstream world and describing it and secularizing it. And what we've seen over the last 40 years is the adaptation of mindfulness to different populations. So chronic people with chronic pain, people with recurrent depression, people with chronic stress, and that it works, that it can be very, very effective. And the early days of the studies, researchers would ask, do you feel better? Do you have less pain? Do you have less anxiety? And more recently, in the last 20 years or so, 15, 20 years, we've seen much more kind of physiological studies. We've seen neuroimaging studies where we can actually see changes in brain structure and function as a result of practicing mindfulness. There's measures, impact on immune system markers. We've lots of data looking at telomere length in cancer survivors. And so I became interested in mindfulness. I first learned about mindfulness as actually a treatment for borderline personality disorder. So individuals who have a lot of really intense emotions and trouble coping with those emotions. And Marsha Linehan, who is a psychologist at the University of Washington in Seattle, she developed a treatment called dialectical behavior therapy. And one core component of DBT was mindfulness. And what she showed in her work is that teaching these individuals who have these really chronically escalating emotions, that teaching them to tune in and be with the emotions and ride them out was far more effective than distraction, than just deep breathing, than medications, than other strategies that people were using. And it just intrigued me so much, this concept of kind of tuning in trumping tuning out. And I was doing some research with cancer survivors at the time, looking at the impact of cancer treatment on sexual health. And it struck me that a lot of the survivors I was working with were, they were describing the changes in their sexual function, with such despair, such disconnection, such loss, profound changes in who they are. And it just struck me, could this tool be helpful for this population of cancer survivors? So that's where it started. And that was in 2002. And what we found now in 23 years of doing research on mindfulness for sexual concerns is, first and foremost, women are very motivated to practice these skills. They're very motivated to, and we've followed women for a year and beyond, and they continue to practice these skills well beyond when they do our groups. Number two, we've seen significant improvements in desire, distress, vaginal pain, many indices of quality of life, sexual satisfaction. And that these are tools that are pretty accessible, right? It doesn't cost that much. As I said, they're motivated to do them. And so I think that we've actually, as a result of that, seen mindfulness now included in international guidelines for managing sexual problems in women. There's a growing amount of research looking at mindfulness skills in men, but we need a lot more research in that area. And so I think that they're an incredible tool for women to have.
Wow. And this mindfulness, we're talking about, are we talking about pleasure or are we talking about arousal? What part of it, or are we talking about the whole act of from beginning to end?
Yeah, great question. So in our studies, we tend to measure desire, arousal, sexual satisfaction, sexual distress. We've also measured physiological sexual arousal. So you bring women into a private research laboratory and they insert a vaginal probe that provides a bit of an indirect measure of physiological sexual response. But what they tell you, so that's what we measure in the research setting, but what they tell you when we do qualitative interviews is they talk about more pleasure. They talk about more presence in their sexual life. They talk about more connection to their own sexual identity. So these are the kinds of things that we don't measure in research. We should be measuring these things, but they're hard to measure because how do you define pleasure?
Right.
so so that's a bit of a snapshot of what we're measuring.
And yeah, it just sounds so obvious right now as we speak that when we talk about eating mindfully, and if we actually put that raisin in our mouth and allow us to feel the sweetness over a few minutes or seconds, it definitely tastes much nicer than us mindlessly involving it in one bowl of porridge and just being a part of something. So
Yeah,
it just sounds so obvious, but perhaps not something that someone is mindfully um, integrating into their sex life.
yeah,
So
yeah.
yeah, yeah. Okay, so thanks for sharing that. Um, we spoke about mindfulness now, but I want to go back to spontaneous versus responsive desire, the difference between them. And we've seen, I hear women say this all the time, about just not wanting to, whether it's distressing
Mhm.
them or not, but the
Mhm.
whole desire bit is like,
Mhm.
it sounds like a chore. Oh my God, now my partner is going to ask for sex, and
Mhm.
oh my God,
Mhm.
I don't want to do this. So if one is not going to have spontaneous desire,
Mhm.
then what is responsive desire, and
Mhm.
can it really replace this
Mhm.
spontaneous desire?
Yeah, yeah. The answer is yes, but I'll provide kind of the bigger picture. So there's actually been a really elegant series of studies looking at motivations for sex. So the reasons that people provide for why they have sex. And this started back in 2007, huge study polling thousands of men and women across different ages. And the researchers asked the people, why do you have sex?
Mm,
And then they took all of those reasons and they distilled them down into 237 distinct reasons for why people have sex. So again, it might be desire, it might be because I have desire, but it could be to show love, to feel closer to my partner, to get to sleep, to celebrate a birthday, to get revenge, to get pregnant, to again the list goes on.
yeah.
237 different reasons. Now, among all those reasons, the 237 distinct reasons, they can be further classified into two big groups: approach related reasons and avoidance related reasons. And these are part of the bigger kind of motivational system that's been applied to many other motivational behaviors before it was applied to sex. So, approach related reasons would be reasons to get something good, right? I have sex to get closeness, feel better, express love, show desire, what have you. Avoidance related reasons would be I have sex to avoid something bad. I have
Mm,
sex to avoid resentment from my partner, to avoid a fight, to avoid a belligerent household, et cetera, et cetera. across the board and unequivocally, we say none of us, no person should be having sex only for avoidance related reasons, right? None of, even the best sex therapist is in the world is not going to be able to make that a good sexual encounter. It's a fast track to resentment if the only
Mm,
reasons that you're having sex is to avoid some bad outcome.
mm,
Um, and then on the other hand, looking at approach related reasons, we actually have a lot of scientific evidence that we can try those on. We can imagine approach related reasons. This is something, some of the things that I do as a sex therapist is I'll work with people to say, and I'll actually hand them a list of, 50 different approach related reasons, and I'll get them to imagine, could that reason potentially be a motivating reasons for why they might have sex with their partner? So they kind of come up, they brainstorm a list, maybe 3 to 5 different reasons, and then they really try and kind of tune into those reasons when they're feeling sexually neutral, right? So
mm.
again, this has been tested in experimental studies and in daily diary studies that we can manipulate approach related reasons. It can translate into more desire for sex, and that it potentially could be used as a therapeutic treatment for people who say, as you pointed out, I have no desire whatsoever. If I never have to have sex again, I would be very happy to do that. So, yeah. So obviously, it takes a bit more work than it happening just kind of spontaneously without thinking. But I think it also then allows people to really tune into the rewarding aspects of sexual activity. If you're going into it, to get closeness, you can then measure that afterwards and say, yep, got closeness. That was well worth the time, well worth the
Right,
effort. And that
right,
would then motivate you the next time.
right. And are there any specific studies amongst perimenopausal or postmenopausal women when it comes to using responsive desire?
So there have been a few studies because, unfortunately, most of the intervention-related studies looking at desire in midlife women have been medications, far less
Mm,
kind of psychological intervention. So I collaborated with an internist, Holly Thomas, and we actually ran mindfulness groups for perimenopausal women with low desire, and found it was very effective. And I mean, we've been running mindfulness groups for a very long time, but we haven't run groups specific to perimenopausal women.
mm, mm,
So we're starting to see more of that research now. I think in part because we're talking about menopause more often. Finally, thank goodness we're finally talking about menopause more, and that the sexual concerns that happen go beyond the genital urinary complaints. It's, desire is a really important aspect of quality of life and identity, and so we should be talking about that more.
right. And I guess this, certain characteristics of this group, if a woman who hasn't slept because of night sweats is definitely not thinking about having sex.
Yeah,
With that belly fat creeping in, then you've got the other layer of body issues. So I guess it's a more nuanced
yeah,
group of women, and separating these things out
yeah,
in research, I don't know how challenging that would be for you and your colleagues.
yeah.
So,
Yeah,
yeah.
I think, that's I mean, even as a specialized sex therapist, I start with the foundational things. Are you sleeping? Are you
Mm,
eating? Are you drinking your water? Are you getting exercise? What medications are you on? I think that's
right.
where all of us healthcare providers is we start and look at those kind of foundational pillars of health, because I can't wave a magic wand. If
Mm,
someone is not sleeping because they're having 45 hot flashes a night,
mm,
I'm going to really struggle to help that person find some desire. The best thing that I can do is help them work on their sleep.
mm. And I think as we are getting more and more aware, there's at least an integration of sex and vaginal health um, in in a whole body system. Otherwise, it's
Yeah,
like, oh, this is my body, and oh, sex and vagina, they're like separate.
yeah,
So to look at it as a system is becoming more common now, which is great
yeah,
to hear.
yeah.
Um, About now going back to desire, arousal, and pleasure. And if we are looking at mindfulness during pleasure, how does that loop work then? If one starts, where does one start working?
Yeah.
Postmenopausal woman, no desire, no arousal, hence no pleasure.
Yeah.
But how does one start working? Like today, I walk into your office and say, I have no desire.
Yeah.
I'm not even sure if it bothers me, but you know what?
Yeah.
I read somewhere that I could do something about it. So
Yeah.
where do I start?
Yeah, yeah, great question. So even in our mindfulness groups or in the books I've written, I really advocate for adopting a general mindfulness practice in your life in general, right? So we could all benefit from more presence in our life, in the
Mm,
conversations we have with people, in the meals that we prepare, in the walks that we take. It's a skill that can benefit every single one of us, regardless of, if we're struggling with anxiety or sexual problems or other things. So that's where in our own work in my writing, that's where we've started. And that's why, for the first several weeks, I help people to adopt a general mindfulness practice. So mindful
mm,
eating, mindful walking, the body scan practice, mindfulness of breath, mindfulness of thoughts. And then we gradually from there, once the person feels like, oh, okay, I'm starting to see the patterns of my mind. I'm starting to notice what are the kinds of triggers that pull me away from the present moment. Is it when I'm bored? Is it when I'm anxious? Is it, when I have certain thoughts that I tend to get pulled away? And so once a person starts to have those skills, then we gradually move those skills into more body oriented and eventually sexual scenarios. So one exercise I love to do is have the person, stand in the shower and practice mindfulness in the shower while where they're smelling the soap or smelling the water and listening to the sounds and looking at their body non-judgmentally and maybe
mm,
even using their hands to touch and really tune into what are the actual physical sensations, not what am I thinking about my body, but what are the actual bare sensations I'm experiencing. And then from
mm.
there, we can gradually progress on to doing this using a handheld mirror and observing one's genitals. You can use the hand and touch the body in a non-goal oriented way. So just for the purposes of noticing sensations, we can gradually move it along to self-pleasuring or masturbation, and then gradually moving it along to, if the person is with a partner, moving those skills into the sexual context. So our groups tend to be 8 weeks long. And in my book, Better Sex Through Mindfulness, I describe it as a program that one could do over the course of 8 weeks. And of course, every person is different. Some people want to spend more time, some people want to spend less time. But I think the point of it is that these are, actual skills and exercises that we need to practice. We don't just
Mm,
decide to be mindful. We actually have to teach the brain
mm.
how to attend to the present moment non-judgmentally, because although we're born with that ability, we lose it over time, right? Our society and our work and everything around us molds the brain to be highly adaptable and flexible to move everywhere. But that's not how we were born. We were born with an ability to be present and very attuned. So it's a matter of practicing those skills again.
Wow. And you said it that this it's an 8-week course. Is it available online or is it described in your book, Better Sex Through
Yeah, so
Mindfulness, is
so
it?
both. So Better Sex Through Mindfulness describes it. The workbook actually walks people through, and then
Mm-hmm.
we have developed. So myself and I have a co-founder. His name is Kyle Stevenson. We've developed a digital tool called eSense,
Mm-hmm.
and eSense delivers both mindfulness-based therapy and cognitive behavioral therapy, primarily to women with low desire. We've been doing research on it since 2017. We've published a fair bit on its efficacy and how well it works. And now, over the next year or so, we're working on commercializing it, making it available to clinics, making it available to anyone who wants to use it. So, esense.health is where people can find out more about it.
It isn't yet available commercially, right?
No,
I did
it's
have a
not
look
yet.
at the
Not yet.
yeah, yeah, yeah,
No, we're getting there because we
yeah.
were we were pretty committed to doing the science first. to show
Mm,
that it works, to making improvements. The entire site was co-designed with patients, people with lived experience. And so with each iteration, we made changes to the platform to make sure that it really was understandable and usable and
mm,
satisfying. And of course, that it
mm.
works too.
And one can do this sitting at home.
Correct. Correct.
And I think that is that's probably the the USP of the tool,
Yeah.
considering so many women are so hesitant to visit someone and
Yeah.
talk about sex
That's right.
and talk about topics like masturbation. Like you just do not hear it often
Yeah.
enough,
Yeah.
especially with women.
Yeah.
And I guess there are two parts to this. Of course, all of us need to try and get rid of the stigma associated, the taboo associated with sex. But in the meantime, at least can we offer this online tool so that women can do this sitting at home?
Yeah.
So that's I think that's wonderful. Um, about changing bodies as a woman is evolving, that belly fat is coming in, there's this, you look in the mirror and you're just not so happy looking at yourself anymore. Um, Again, does mindfulness play there, or how does one approach this at perimenopause? I
Yeah.
think going through the change is harder than being beyond because then
Yeah.
you're used to this other person.
Yeah. Yeah.
But how does one deal with it at perimenopause?
Yeah, yeah, and body image, is a
Yeah.
very gendered phenomenon, and women, even without perimenopause or other changes, are incredibly impacted by body image, and it's because of societal stereotypes around what is desirable. And so it just takes me back to the question you asked earlier around the need for kind of systems level changes in what we view as beautiful, right? And
Mm,
that beautiful is so much more than what one sees before your very eyes. So there's a lot of distress that women have through the perimenopause and through, especially if there's visceral fat gain, et cetera, especially among women who are saying, I'm doing all the right things. I'm eating the protein and I'm exercising, I'm getting 10,000 steps in, and it's still happening. There can be an incredible amount of distress associated with it. And so I do think mindfulness can be really helpful there because mindfulness essentially targets distress. That's what it does. It's
mm,
that's one of the ways that mindfulness works is it helps by helping people stay very present with sensations. It creates distance from distress, and distress is a cognitive or psychological phenomenon. It's a worry about something or worry about something that's missing or something that is there. And by staying present repeatedly over and over without judgment, it directly targets distress. And in fact, that's what John Kabat-Zinn showed in the very early days of how mindfulness helps people with chronic pain. It's not that it took the chronic pain away,
mm,
it's that it targeted the distress so that they could accept who they were, they could accept their limitations. And as soon as they did that, the pain intensity actually went down. The pain
mm,
intensity went down when the distress went down. So, to answer your question, I absolutely think mindfulness is useful to women who have distress associated with body image or distress associated with word finding problems at midlife
mm,
or other
mm.
challenges that are common during the perimenopause.
So just as an example, if let's say something is bothering me just now, let's just say it's visceral fat for now. It's distressing me, so it's creating anxiety for me. Now the distress is anxiety about visceral fat. And if I want to be mindful, what does it mean? You said I have to over and over again. Uh, yeah, I have to revisit it. You said is that what you mentioned? Yeah.
Yeah, so it depends on the particular practice. So within
Mm,
mindfulness, there's different practices. Just like if you go to the gym, you might have a leg day and a
right.
upper back day and an arm day. Mindfulness is the same thing. You might practice the body scan, which is about really tuning into body sensations. You might practice mindfulness of thoughts,
Mm,
which is that's not the same as analyzing your thoughts. That's a different kind of therapy. But mindfulness of thoughts is observing the fact that you're having lots of thoughts and being
Mm,
able to kind of put thoughts into certain buckets. Oh, that's a worry thought. That's a planning thought. That's a memory thought. And so you create a bit of space between you and the thought itself. So
mm,
to your question about, what are you actually doing
mm,
to manage distress associated with body image? One of them is through mindfulness of thoughts practice. So you might, through a guided practice that's 20 minutes long, actually practice staying very present, but observing the stream of thoughts that happen moment by moment by moment, and by kind of labeling them as planning or distressing or what have you, you actually create some space between you and the thought. So that's one of the way distress goes down. And then through a body scan practice where you're tuning into the bare sensations in your body, you're noticing tensions, you're noticing places of relaxation, you're noticing temperature, you're noticing vibrations. And so
mm.
you're really moving into the bare sensations, right? And again, when you do that, then it reduces the chance of thinking and emotions.
If you've been struggling with vaginal dryness, discomfort, painful sex, or recurrent UTIs, or if you're a healthcare provider who wants to feel more confident about diagnosing and treating the genitourinary syndrome of menopause, check out our new courses at MenopauseWize.thinkific.com. For women, there's VaginaWize, with clear, simple lessons on how to choose the right lubricants and moisturizers, how to use vaginal estrogen effectively after discussing with your provider, what daily habits actually help, and even downloadable guides with trusted product recommendations for both India and North America. For providers, there's GSM-Wise, with evidence-based, guideline-driven strategies to diagnose, counsel, and treat GSM with confidence, including practical guidance on all treatment options from over-the-counter to prescription drugs. So visit menopauseWize.thinkific.com to learn more, or look out for the link in the show notes. I'll see you there.
Mm. Wow. Thank you for that explanation. Now, while you were, I was uh, trying to visualize what you were saying,
Mhm.
and now let's say I'm just going to throw a scenario out there. Let's say I'm a perimenopausal woman who is in general anxious or even postmenopausal, um, and anxiety has just become the second me. And in such states, it becomes even a step harder to be mindful. It's like you want to say, are you crazy? Like, I can't stay still just now. I'm so anxious. So
Yeah,
how
yeah,
does one get over that
yeah,
step to even get started?
yeah,
Is that something that's covered in your book, or because
yeah,
that's that
yeah,
inertia to even start off with it, because it
yeah.
just seems unreal at that point.
Yeah, yeah, great example, and I think a common one that people can relate to. These skills are so much harder to implement when we have a high level of emotion, anxiety, depression, other emotions there. So that's why we want to practice when we're feeling neutral, right?
Mm,
That's when you want to get really good at that skill.
mm,
We go to the gym when we're feeling neutral. We don't go to the gym, when all the odds are stacked against us. So we want to work up towards that. So I do think that that's why it's important that we just kind of commit to incorporating mindfulness in our lives. And we're not saying it has to be an hour a day, every single day for the rest of your life, but we start in small bite-size bits. So maybe it's, you start with 3 minutes once a week, and you kind of build from there. I think to the question of, how do you overcome inertia?
mm,
And this is where, again, I can't wave a magic wand and convince people. What I can do is I can share the science because I'm a scientist, and I can point to the studies that show us that unequivocally, and there have now been hundreds of studies that have been done on mindfulness for a variety of different issues beyond sexual
mm,
health, but depression, anxiety, stress, anger, binge eating, etc., the data are so compelling to show that it works, that it works.
Mm,
In
mm,
my research, one of the things that we've measured is women's degree of skepticism about mindfulness and whether that predicts them doing poorly.
mm.
And it turns out it doesn't predict it at all. And we've now tested that in a variety of studies. So this is good news because it means that whether you practice yoga and you have mind body medicine as your field, or you're totally skeptical and the only reason you've signed up for this mindful sex group is because it's the last thing that's offered to you. It doesn't matter that your degree of kind of belief in this working doesn't predict who does well and who doesn't, that both groups are equally likely to benefit from it.
That's really interesting because I would have assumed, because that was going to be my next question, is if I don't believe that it's going to work, then it's so much harder for me to follow. I'm a process person. Someone tells
Yeah,
me this is a process, you will reach an outcome. I will do it every single day, knowing
yeah,
that there is, there is light at the end of the tunnel, and that's about it. Be patient with
yeah,
the process.
yeah,
Um, but if I am a non-believer,
yeah,
or I'm skeptic about, I
yeah.
guess there must be some belief for someone to actually find out about it and follow it, right? Some basic amount of faith that maybe it works.
Yeah,
Uh,
yes, but we've had a number of women join our groups who've said, I've tried the medication, I've
mm,
tried exercise, I've tried sleeping better, I've tried
mm,
communications training with my partner. I'm here because this is my last resort. So we've had
mm.
a fair number of those women in our groups as well.
Wow. This is motivating and inspiring to get started with being mindful about eating, and then at least getting started where you are with whatever
Yeah,
works for you, and then
yeah.
it resulting in better sex. It sounds like a complete win-win situation to me. Um, if there were um, three empowering thoughts about sex and menopause, perimenopause. This group specifically, just because there's so much going on. Sex is just not something that eh, it's accepting that slow death, or
Yeah,
it's either distressing you, or you're beyond. But
yeah,
three empowering thoughts for women going through perimenopause and menopause for better sex.
yeah. I would say it's a myth that sex ends with menopause. That's an important one because that has been a myth for the longest time. I think another message is sex can be better after menopause. That a bit provocative, but it certainly can be better after menopause, especially if a woman has had very heavy bleeding and you know lots of escalating emotions around this, so it can be better. And then the third thing is probably everything you need for blissful and pleasure filled sex you already have.
Hmm. Right. Well, that is empowering. And I guess for a lot of women, we're post-menopause, a lot of them have reached a stage where, the children have gone away, there's
Yeah,
more time to yourself,
yeah,
you understand your body perhaps a little better.
yeah,
Would most women be a little more
yeah,
comfortable with themselves? So it definitely
yeah,
does sound like
yeah.
a place where one can have better sex then.
Yes. Yes, I totally agree. And I think we need to share that narrative more. It's not meant
Mm,
to ignore or dilute the real suffering that huge numbers of women have with untreated menopause related symptoms. But it really can be better. It can be better on the other
mm,
side. And it's, all of the more kind of identity related things, a sense of confidence and ease and, hopefully certain things in life are easier on the other side. And all of those things are actually really important for sexual desire and pleasure.
mm. I'm going to go back to pleasure, but with women seeking pleasure, is there in your practice, have you observed a difference between men and women seeking pleasure, as far as the proportion of women who actually ever achieve orgasm in their lifetime? And will that play, or does that play a role in desire? If my endpoint isn't pleasure, whether orgasm or not, if I do not achieve pleasure, I'm not motivated to go for that second round of sex after a month or whenever that it is. So
Yeah,
in
there's a
general,
lot in that question.
I'm so sorry that I
Yeah,
have
there's
a
a
lot of
ton.
questions for you.
You talked about gender differences. You talked about pleasure versus orgasm, the orgasm gap. Yeah, there's about 18 questions in there. I mean, there are differences between men and women, even in
Yeah.
how we talk about pleasure, and in that men are more likely to wrap it up into orgasm, whereas women are not. And plenty of women will say that they experience sexual pleasure even without orgasm. And so I would say that indeed pleasure is quite necessary for sex to be rewarding, although orgasm is not necessary. Orgasm is a nice to have, but it isn't a requirement to have. Now, having said that, going back to the gender differences question, there are huge gender differences in males versus females in who reaches orgasm. We call it the orgasm gap. And a big part of that is because women are not stimulating their bodies, or they're not receiving stimulation to the part of their bodies that are more likely to lead to orgasm, right? So intercourse for the majority of females doesn't lead to orgasm, whereas clitoral stimulation does. And um, so yeah, that's a bit of a
Okay, thank
reaction to
you.
the
Thank you.
question.
All right. Well, I can come out with another 237 questions just like you said that. But
Oh,
I think this is all that we have time for
great.
today. But
That's great.
thank you so much for
My
this. It's
pleasure.
been enlightening, and yeah, I'm looking forward to eSense
Thank you.
and your book, Better Sex Through Mindfulness.
Thank you.
So
Thank you for a
thank you for
great
sharing that.
conversation. I really enjoyed it. Thank you.
Likewise. All right. Bye-bye.
Bye bye.
Bye.
Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.